Good afternoon, everybody. Thank you for joining us today as we share with you our work from this semester. We believe that our project, an ergonomic coupling system for peritoneal dialysis, has the potential to revolutionize the way dialysis is done worldwide. Our vision is simply to get more people on at-home dialysis. We sought to do this by developing and testing an improved connection system to make at-home dialysis more accessible for patients with physical or cognitive impairments. But before we delve into the details of our design, I want to take a minute to introduce to you our team. On the student side, we have Jose Martinez, Ricardo Hopker, and myself, Pedro La Rota, joined by an excellent team of mentors and advisors, including Dr. Alexander Blair, who pitched this project to the class this semester. So let us begin with a bit of background. The disease area we're interested in is end-stage renal disease, ESRD for short. Patients diagnosed with ESRD have lost almost complete kidney function and in lieu of a kidney transplant, need to undergo dialysis to survive. There are two broad categories of dialysis treatment. Hemodialysis, which involves filtering the blood of the patient through an external device, and peritoneal dialysis, in which a special solution is delivered into the peritoneal cavity of the patient and the blood is filtered within the body. While hemodialysis is most frequently done in the hospital setting, peritoneal dialysis can actually be done at home, giving the patient greater sense of control and independence over their health. In addition to the increased quality of life peritoneal dialysis offers, studies also show peritoneal dialysis offers some cost benefits and even increased patient outcome in the short term. Despite the benefits of peritoneal dialysis, and despite at-home dialysis being the preferred treatment modality for around 65% of patients in the US, at-home dialysis is only done by around 10% of patients. These figures suggest that many patients either opt out or simply don't qualify for peritoneal dialysis. Patients are often disqualified because of physical or cognitive impairments, complicated at-home dialysis systems that are out of their reach, and overall risk for infection. The current gold standard of care for peritoneal dialysis systems is this Baxter Home Choice Cycler. While this system automates the flow of liquid into and out of the patient's peritoneum, the setup and usage of this device is complicated and requires significant dexterity from the patient.
In studying the setup process for at-home peritoneal dialysis, it is clear that the number of entry points for infectious microbes would be a source of concern in the decision to adopt this treatment. The risk of infection is directly in the hands of the patient and depends on how strictly they maintain sterile technique when forming key connections in the system. We identified the patient-side catheter connection as the highest risk source for infection and set out to address this problem with our fluid connection device. Using this problem definition, we defined three functional requirements. The first is that our device will sterilize itself, therefore taking this responsibility out of the patient's hands. The second is that it be easy to use, so that the device can be more accessible to the physically impaired. The third is that it be a watertight connection, to avoid any loss of the dialysate solution transmitted during treatment. Using our newly defined functional requirements, we decided to split our design solution into three subsystems. These are our sterilization solution, fluid connection mechanism, and accessibility mechanism. We took all three into an analysis phase, where we used first-order analyses to inform our design decisions. We then further developed our fluid connection and accessibility mechanisms into a physically integrated prototype. This prototype was then tested to understand its fluid performance and dexterity requirements.
Our connection design is composed of two terminals. On the left, we have the male connection or the catheter connection, which is attached to the patient. On the right, we have the female or disposable connection that is connected to the dialysate fluid. They work by axially mating two spheres that push each other, allowing fluid to flow. Next, we'll show you the evolution of our designs. Starting on the left, we have our hand-drawn concepts, following by our proof of concept using off-the-shelf components to test our overall approach. As we progressed, we used CAD models and engineering analysis to incrementally improve our design until we reach our first prototype on the far right. One of the most important aspects of our design is to allow fluid flow from the female to the male connection in a controlled manner. The spring parameter optimization analysis determines the order of the opening of the chambers to allow sterilizing fluid to flow and clean the connection. Stress and force analysis was performed in the case and the ball to determine the dimensions and materials of our connections. Deflection of the case was analyzed in FEA to assure the encasing of the ball. Lastly, fluid analysis was performed to assure the connection was practical in our use without hindering delivery and removal from dialysate fluid from and to the patient. For our final prototype, a quick connect connection was designed using a mix of off-the-shelf components and 3D printed parts. On the left, you can see a cross-section of our design, and on the right, a picture of it. The spring and ball system makes this system easy and quick to connect and disconnect. It also enables for us to design the opening sequence of the chambers, controlling the disposal of the sterility fluid as intended, from the disposable to the catheter connection. It also makes the connection self-locking in case of an accidental disconnection. The black clips keep the system connected during use, and we mitigated the risk of leakage by adding an O-ring in the catheter connection and by having a long threaded connection between the case and the barbed fitting. The minor loss coefficient through the connection was estimated and deemed reasonable. We then proceeded to test our prototype. The first test was to check if an unconnected single connection would leak. So a column of water was attached to the terminal, where we left it overnight. We then observed the height difference in the column and the falling drops. The next test was conducted in a similar fashion. However, this time we connected the male and female sides and observed the leakage of the connection while in use. Our last test was to estimate the pressure drop through the connection. We did it by timing how long it took for a column of water to flush through the connection. In test 1, we observed very few drops of leakage, what we judged to be acceptable. In test 2, there was no leakage throughout the test. While in test 3, there was no significant pressure loss and the results matched the theory in our previous analysis as shown in the plot in the lower right corner.
The goal of our accessibility mechanism is to lower the physical requirements necessary for forming the catheter fluid connection. It does so in two ways. The first is by amplifying the force provided by the user through the toggle clamp lever and into the connection interface by 3 times. The force amplification works through the 2-bar linkage design of the over-center toggle clamp that we use to move the carriage holding the catheter terminal. The second accessibility method is the constraining of the terminals. By placing both connection terminals in the magnetically fastened terminal clips, the user no longer needs to worry about the alignment of each connection terminal during the formation process. In order to assess the efficacy of our connection system for making the connection process easier, we tested the existing solution, our insertion solution, and our insertion solution with the accessibility mechanism in a variety of dexterity scenarios. What we found through this preliminary testing is that the existing connection solution works best when users were unimpaired. However, as users begin to lose dexterity in these scenarios, they found our insertion mechanism easier to operate. As they got to the extreme end of dexterity loss in the one-hand scenario, our accessibility mechanism became almost necessary for users to feel secure during the forming process. What you'll see in this video is our final integrated solution being used as we expect a real user would.
Our final design parameter was sterility. While decreasing the number of parts and the complexity of the connection in itself made our system easier to clean than existing connections, we decided to propose a method of use for our connection that did not rely on the patient's ability to wash small parts. We designed our system so that it could be preloaded with a small volume of pressurized sterilization fluid in manufacturing, so that when the connection is initially made, the sterilizing solution flushed the connection, killing any potentially harmful microbes introduced by handling. A significant barrier in the deployment of this idea is that the sterilization solution would inevitably end up in the peritoneum of the patient. While we identified hydrogen peroxide as a minimally toxic and effective sterilizing solution from CDC and SDS data, we acknowledge the need for thoroughly evaluating this concept before any sort of implementation. Our ambitious design addressed all 3 of our functional requirements. While we were unable to confirm the validity of our concept for sterilization, we were able to identify a potential sterilization agent and devised a way for preloading it into the connection for preliminary testing. We gathered preliminary user feedback suggesting that our mechanism shows great benefit over current systems. And lastly, we thoroughly tested the ability of our connection to hold flow without leakage through a series of tests with water. We hope to go through several additional design iterations before moving further in the medical device regulatory pathway. One of the takeaways from user feedback is that our connection is currently a bit too large and feels slightly too heavy to the user. The hope is to remove the metal parts and injection mold a scaled-down version of this device in the future. This, in addition to further development of the self-sterilization concept, is our plan for future development of our device. Thank you for your time. Do you have any questions?